The human elbow is a hinge in near constant motion. Every time you flex, extend, or lift, the joint generates significant mechanical stress. For hard structures like bone and tendon, this is normal operation, but for delicate tissues, this constant articulation creates a hazardous environment. This creates a major anatomical bottleneck. Vital nerves and major blood vessels must travel from the upper arm to the forearm and hand. They have to cross this exact pivot point without being crushed during flexion or overstretched during extension. The biological solution to this problem is the cubital fossa. As seen in this text description, it's defined as a triangular hollow space situated on the anterior aspect of the elbow joint. It sits precisely at the transition point on the front crease. In clinical practice, this region has a dual identity. On the surface, it is the most accessible site for routine needle access, but deep down, it operates as a heavily protected transit conduit. Navigating this region safely depends on a three-dimensional model of its layers, mapping the space from the superficial venous roof down to the muscular floor. Understanding this spatial logic determines whether a routine blood draw succeeds or whether an incorrectly placed needle causes iatrogenic injury to the nerves and arteries hidden just below the surface. To build this three-dimensional map, we start at the widest geometric boundaries and work our way inward. The overall shape is a triangle pointing downward. As noted here, the inferior apex is formed exactly where two major forearm muscles, the brachioradialis and the pronator teres, converge and meet. Closing off the top of this triangle is the roof. This is the superficial interface located directly beneath the skin. Figure 8.14 shows the superficial fascia houses a visible network of veins. The outer lateral boundary is the cephalic vein. The intermedial boundary is the basilic vein. Diagonally between them, the median cubital vein acts as a bridge linking both systems. Because it is superficial, large, and generally anchored well by the surrounding tissue, the median cubital vein is the universal primary target for venipuncture, including routine blood draws and intravenous line placements. This extreme accessibility makes the cubital fossa the most frequently utilized anatomical site in daily medicine, but it also sets up a high-stakes scenario. Clinicians are repeatedly inserting sharp needles directly above vital delicate structures. When a needle enters the vein, a critical question arises. What physical barrier stops that needle from piercing the deep structures below? The answer lies one layer down in the deep fascia. Figure 8.14 highlights a critical structural reinforcement, the bicipital aponeurosis. This tough, broad band of connective tissue radiates downward from the biceps. Positioned immediately deep to the median cubital vein, it forms a distinct layer isolating the interior cavity. The bicipital aponeurosis serves as the primary structural shield of the elbow. It functionally isolates the safe, superficial access zone from the vulnerable deep conduit. Before analyzing the contents of that deep conduit, we need to establish its foundation. We bypass the neurovascular bundle for a moment to define the absolute bottom of the space. If delicate nerves and arteries were compressed directly against the hard bones of the elbow joint during flexion, they would sustain mechanical damage. They require a soft, forgiving bed. This cross-section in Figure 8.17 maps the deep topography. The lower structures form the muscular floor. On the inner, medial aspect, the brachialis muscle rests over the ulna. On the outer lateral aspect, the supinator muscle wraps around the radius. The convergence of the brachialis and supinator creates a V-shaped muscular trough. This design ensures that the deep neurovascular bundle is cradled securely and protected from bony compression every time the arm bends. We can now examine the primary payload, sandwiched between the fascial roof above and the muscular floor below. These deep structures do not float randomly. They maintain a rigid, predictable spatial orientation along a strict lateral to medial axis, meaning from the outside of the arm moving inward. Clinicians navigate this axis using a core anatomical mnemonic, TAN. As shown in the center of Figure 8.17, this dictates the exact order of the structures. T stands for the tendon of the biceps brachii. Positioned as the most lateral structure in the bundle, this robust tendon serves as a physical landmark that is easily palpable through the skin. A stands for the brachial artery, located immediately medial to the biceps tendon. This is a critical transition zone for blood flow. It is precisely within the apex of this fossa that the brachial artery bifurcates, dividing into the radial and ulnar arteries to supply the forearm and hand. Finally, N stands for the median nerve. The median nerve is the most medial structure of the primary triad, running furthest toward the inside of the arm. This strict TAN ordering acts as a reliable biological coordinate system. A practitioner can palpate the prominent biceps tendon, knowing that by moving just medial, they will find the brachial pulse, and by moving slightly further medial, they must exercise extreme caution to avoid the median nerve. With all the individual components mapped out, we can reconstruct the entire anatomical gateway, starting from the muscular trough and the deep TAN bundle. Over that vulnerable brachial artery and median nerve, the bicipital aponeurosis slides firmly into place, locking down the deep conduit. The superficial venous network is then layered directly on top of this fibrous shield, setting the median cubital vein comfortably in the most superficial fascia. This precise biological packaging allows for a paradox. Superficial clinical procedures remain highly safe, despite occurring millimeters above sensitive arteries and nerves. Integrating these superficial to deep layers with the lateral to medial TAN map provides a reliable spatial guide for every physical examination or intervention at the anterior elbow.